like I'm lying.
Good afternoon and welcome to Grand Rounds today. Please remember to sign the attendance record. Please also remember to fill out the program evaluation. And in addition to soliciting any ideas that you might have in regards to future topics and future speakers, at the last CME committee meeting, we decided that we'd try to put on a series of programs highlighting interesting cases or informative educational cases that the people in the audience see. So if you see something particularly interesting, a zebra or something that you think is particularly illustrative, just if you could just email me, and we'll get a collection of those, and we'll get a Grand Rounds program set up. So today it's my pleasure to reintroduce Dr. Joe Merchant. Dr. Merchant is a hematologist oncologist. He attended medical school at the University of Iowa, then went to the University of Virginia where he did his internal medicine residency, and then traveled from there to the University of Wisconsin where he did his fellowship in oncology. He's here to update us on immune checkpoint inhibitors, and please join me in welcoming Dr. Merchant.
Okay. Hi, everybody. Thanks, Steve, and thanks for inviting me back to talk again. This is really an exciting area of oncology. It's an exploding field for us, talking here about checkpoint inhibitors or immuno-oncology. So I thought I would start with a case, a patient of mine, maybe the first patient who really made me a believer in this, this type of treatment. I'm getting old enough that I'm like the guy who said these cell phones are never going to work out, and you know, this computer, this internet, it's all for, it's not useful at all. But this was my initial skepticism was swept aside by patients like this. And this is a 55-year-old woman who presented with very, very sick with lung cancer. And she had, this is her PET scan, which I think you can all appreciate. This is her liver, and it's, there are multiple large tumors in her liver. This is when she presented. She had been losing weight. I'm not showing the whole PET scan, but she also had numerous bone metastases in her ribs and spine. She was in a great deal of pain, and when I met her, she had to be admitted directly to the hospital simply for pain control. She had a liver biopsy which showed a non-small cell lung cancer. She had a small lesion in her lung, and she, at this time, the checkpoint inhibitors were not available, and she was treated with standard chemotherapy, carboplatin and Taxol, which is very toxic and made her lose her hair, provided a very short reprieve in terms of symptoms. She then went on to receive a different chemotherapy, gemcitabine, had very little response, and then went back to a different, a third-line chemotherapy, which was even tougher, and she didn't respond to that and really was nearing hospice. We gave her, around this time in 2015, we were able to access this drug, nivolumab, that I'm going to talk about and in some detail today. And she received that drug, and within 3 months, her liver, here's a CAT scan, her liver is almost completely in a remission. There's one little lesion you can see here. The patient felt better amazingly quickly and had a dramatic reduction in her symptoms from cancer, improvement in appetite, and improvement in pain, improvement in activity. She was able to resume a lot of her normal activities, take several long trips with her family, including international travel. Hair grew back, and she felt wonderful. And it seemed like a miracle. Her side effects from the drug were very, very minimal. And she had a response that effectively lasted 2 years. And I know my partners are seeing the same kinds of responses. So let's talk a little bit about nivolumab and checkpoint inhibitors and how do they work. The biology, and I'm not an immunologist, but to sort of simplify it, cancer cells are very dirty cells. They shed a lot of protein. And we have cells in our body that are intended to pick up protein that is foreign, present the protein on the surface of those cells. These are called antigen-presenting cells. And then those cells trigger the T cells, part of our immune system, to become activated. So the T cells become activated when they have an antigen-presenting cell presenting an antigen. The antigen-presenting cell says to the T cell, here's something you should care about. The T cell then develops a specific response to that antigen and circulates in the bloodstream looking for that antigen. When it finds that antigen, in other words, when it finds the cancer cell that expresses this protein called a neoantigen, the T cell will destroy the cancer cell using its tools, its sort of bat tools, the perforin, granzymes, to basically directly kill the cancer cell. That's how things are supposed to work, but cancer cells are smart, and they respond to the T cells by expressing proteins on their surface called PD-L1 and PD-L2. These are inhibitory proteins, and what they do is they basically tell the T cells, hey, knock it off, leave me alone. And when the PD-L1 and PD-L2 are expressed on the cancer cell surface, the cancer cell effectively deactivates the T cell response. And this is a process that's been called adaptive immune resistance. This is a cartoon that shows here's the cancer cell. It's a dirty cell. It's secreting neoantigens or proteins. These are picked up by the antigen-presenting cell. The antigen-presenting cell interacts with a naive T cell in the lymph nodes. The T cell is activated into an activated tumor-specific T cell. Now, when a T cell is activated, this molecule PD1 is expressed on the surface of the T cell. You see, PD1 is not on naive T cells. PD1 is an off switch, and it's basically a way of turning off an excess or runaway immune system. Now, the activated T cell will secrete gamma interferon, which causes the cancer cell and cells around the cancer cell, stromal cells, macrophages, other immune cells, to express a ligand called PD-L1, PD-L2. This is basically like a key that fits into the PD-1 lock. When PD-L1 binds to PD-1, it turns our good guy activated T cell into a deactivated and ineffective T cell. And the cancer cell gets to divide and thrive. So this is the basis by which this checkpoint inhibition model has been developed. And that is that here's our T cell, here's our T cell, antigen-presenting cell. These are our drugs right here. What they do is they bind to PD1 and they prevent the cancer cell from sticking its key into the lock to turn off the T cell. So we bind to the PD1. The cancer cell is unable to inactivate the T cell. The T cell gets to carry on secreting perforin, granzyme, and killing the cancer cell. So again, this is some of this you can read in your handout, but cancer cells hijack the immune system, turning off the immune system's ability to kill cancer cells. The checkpoint inhibitor blocks the cancer cell from doing that, and the immune system is free to kill the cancer cell. This probably explains it best. Here's our T cell hero. Here's the cancer cell with its PD-L1 trying to turn off the PD1 on the T cell. And our drugs here come in the middle and prevent that from happening. They prevent the cancer cell from getting to this crucial molecule on the T cells to turn it off. So that the checkpoint inhibitors are a way of preventing this dirty trick by the cancer cell. So giving credit where credit is due, these checkpoints were uncovered by a lot of scientists, but one of the main ones was this Dr. Tasuku Honjo in Japan. In 1992, he discovered this molecule PD1. Effectively, he discovered this molecule here on the T cell. And subsequently, the ligands, that is this molecule here, PD-L1, were discovered in 2000. Other scientists used a mouse model where they were able to show that if you block PD1, the immune system is able to attack the cancer cell much more effectively. And this drug company in Japan called Ono Pharmaceuticals, along with an American company, Bristol Myers Squibb and Medarex, they developed a monoclonal antibody called nivolumab in 2006. Again, this molecule blocks this PD1 from being turned off. Clinical trials with nivolumab were begun in 2009. In 2014, we got the first approval for use of nivolumab in melanoma. And other monoclonal antibodies have come since then. And one of the other ones we use a lot is pembrolizumab, and we're using more durvalumab and atezolizumab as well. Atezolizumab is a monoclonal antibody that targets PD-L1. So we have monoclonal antibodies that target this and this. This is Dr. Honjo, and one other person I want to highlight is Dr. James Allison of the University of Texas. He discovered another checkpoint of the immune system called CTLA4, and this also functions as a brake on our immune system cells. He was part of the initial development of another drug that we are using called Ipilimumab. Ipilimumab is also a Bristol Myers Squibb drug. It was approved as a treatment for metastatic melanoma in 2011 in the United States. And this is Dr. Allison. I think both of these doctors are going to get a Nobel Prize, but I guess we'll see. These are some of the drugs that we're using, some of the dates of approval. You can see this is all happening relatively recently. And so we oncologists are just getting used to it in the community. Right now I'm going to talk to you today mainly about melanoma and lung cancer, but effectively all cancers now are under investigation for clinical trials for a variety of different immuno-oncology drugs. And so whether you have leukemia or pancreas cancer or prostate cancer or whatever, brain tumors, there are a variety of immuno-oncology approaches being investigated. And I'm just talking about drugs here. There are other cellular therapies, which I'm not going to talk about, but you may read about CAR T cell therapy, and that's a different immune oncology approach. So I want to talk first to get into specifics in terms of the evidence about why these drugs are so useful or how they're being used. I want to talk about Dr. Allison's drug, the CTLA4 agent, and mainly focus on the first part of the talk on melanoma. This cytotoxic T lymphocyte-associated antigen 4 is an immune checkpoint molecule. It downregulates T cells, T cell activation, and the ipilimumab is a fully humanized monoclonal antibody which blocks the CTLA4, and it promotes T cell anti-tumor immunity. At the time it was introduced, stage 4 melanoma patients didn't really have very good treatments, and the median survival was less than a year. The initial trial was called the 020 trial. 676 patients with stage 3 unresectable melanoma or stage 4 were randomized in 3 groups to get ipilimumab plus a peptide, which was thought to be stimulating to the immune system, or get the peptide alone, or get a placebo, or get the ipilimumab alone. And the treatments were given every 3 weeks for 3 treatments. It turned out that the peptide, the GP100, didn't do anything, so it was effectively a placebo group. And they were able to show, here are the characteristics of the patients, in case you're interested. These were 55 to 58-year-old patients, mostly more men than women. These were really patients with, they were relatively sick patients with a lot of metastatic disease. Some had brain metastases. All had had prior therapy for metastatic disease. Many had had our previous best therapy for melanoma, which was high-dose interleukin-2, a treatment that puts everybody in the intensive care unit very, very sick. So this was a real solid representation of sick melanoma patients. And they were able to show that the patients who got the ipilimumab had a survival advantage. Now you can see the survival is still only about 20% of people who are having a survival long term. But at the time this was kind of miraculous, because the people who seem to respond have a very prolonged response. And again, they're only getting 4 doses of medicine at the beginning. So this kind of information was why the CTLA-4 antibody was very quickly approved as a treatment for metastatic melanoma. Now, around the same time, again in 2006 through and onward, PD1 inhibitors were developed targeting this other checkpoint inhibitor. And there was a big trial in metastatic melanoma and other diseases. You can see in this trial, which was from 2009 to 2012, they included patients with a bunch of different cancers. They weren't sure what they had on their hands, but they had lung cancer patients, melanoma, colon, kidney cancer, ovarian cancer, pancreas cancer, gastric cancer. It's just interesting to me that this trial took 3 years to accrue enough patients. Nowadays, these trials are so hot, if you have cancer, you want to get in a trial, they fill up right away because patients are excited about these drugs. But they were able to show, again, doesn't seem like much, but these were patients all who had had prior therapy. They were kind of beat up patients. 10% of lung cancer patients, 19% of melanoma patients had objective response rates. And again, the responses were long-lasting. Here are the melanoma patients. Some people progress. Some people just stay stable, and this is, a long, long time. And some people have a rapid response and then stay in complete remission. This is the lung cancer patients. Again, some people just go very quickly into remission and stay in remission. And so they knew they had a very active drug with nivolumab, and they started giving it in patients with advanced melanoma alone. These are called phase 2 trials. In the first phase 2 trial that was published in the New England Journal, they included patients that had previously been treated with ipilimumab. That's the first checkpoint inhibitor I mentioned. They had 48 of those patients. And they also had patients who had not been treated with ipilimumab. To get in the trial, all the patients who had had ipilimumab therapy had to have resolved their side effects. And again, in this heavily pretreated patient population, they had a good response rate of 38%. The majority of people who responded by 12 weeks. And the biopsy specimens of patients with response demonstrated that the tumor was densely infiltrated by cytotoxic T cells. So this is some of what they call waterfall plots, showing in patients in the lighter color, they had prior ipilimumab therapy, and in the darker orange, no prior ipilimumab therapy. At this time, this drug it's now called pembrolizumab. It was called lambrolizumab at that point. But in any case, you can see in terms of best objective response, some patients progress, but the majority of people have a shrinkage of 60, 80, or 100% in terms of their cancer. This shows the timing of their response and the length of their response at the time the paper was published in 2013. The blue triangle shows when did the patient's first evidence of response become evident. You can see this is 10 weeks roughly. So these people who get these drugs, the immune system doesn't wait around. It works right away. People feel better very quickly if they're going to respond. This shows in the red the people who get a complete response, how long does it take? So you get a partial response followed by a complete response. If you notice, this patient here received the drug for almost a year before responding. So we have patients who take these drugs and they wonder, should I keep taking it? My tumor is not shrinking. Is it doing anything? And there are patients, we just have to tell them to hang in there because you may be a patient who will respond. It may take you a year. It may take you longer. And then these are the arrows just showing these people they aren't just stopping responding. Traditional chemotherapy would work 6 months, maybe no more than that. But these people have a response, and then they stay in response. Here's an example of a patient with a large face melanoma. This is the biopsy with the brown cells being the T cells prior to treatment. And then this is from this paper. This is what happens with the immune checkpoint inhibitor therapy. The patient's melanoma disappears for the most part, and these are all the good guys coming to the rescue, helping the patient to respond to the cancer. So now we have 2 checkpoint inhibitors. It's 2013. People are pretty excited, so they decide maybe we should give the ipilimumab and the nivolumab together. Or give pembrolizumab and nivolumab together. They were able to demonstrate, again, that pembrolizumab or nivolumab have a better overall response rate than ipilimumab, and the patients tolerate it better. So this trial is one of several trials. I'm just picking, there are a lot of trials to demonstrate, but this one, Keynote 006, showed pembrolizumab had a 33-month median overall survival, and it was better than the ipilimumab. So anyway, they did this trial, Checkmate 067. They looked at 1,296 patients, and this trial compared nivolumab plus ipilimumab to ipilimumab to nivolumab, trying to pick out is combined blockade of PD-L1 and CTLA-4 better than CTLA-4 or PD-1. And they were able to show that in this trial that 58% response rate for patients who got the combination compared to a 19% response rate for patients who got ipilimumab. And the overall duration of response was 19 months with ipilimumab on average compared to beyond 19 months not reached with the combination. Again, here are the waterfall plots showing a lot of patients responding to the combination of 2 drugs, relatively fewer responding to 1 drug. This got us all excited about using combination therapy. Again, responses tend to happen early and to be long-lasting. This is progression-free survival showing the combination had better than ipilimumab. The problem is the toxicity of the drugs in combination. There are a lot of immune toxicities that come with the combination CTLA-4 and PD-1. Especially ipilimumab seems to be a more toxic drug as far as contributing to autoimmune effects. And this is where it's starting to become important for the medical community as a whole here, because we're giving so many of these patients these treatments. It's important for emergency room and primary care doctors to start being aware of asking the question, what is your doctor giving you over in oncology? Because you're sick in a different way. Patients develop autoimmune inflammatory bowel disease, for example. One of the common effects is to come in with bloody diarrhea, abdominal cramping, and biopsy shows, colonoscopy will show typical ulcerative colitis findings. And patients can become very sick and even die from inflammatory bowel disease. Patients can develop severe skin rashes, very itchy, very red, very uncomfortable. Patients now develop very commonly hypothyroidism, hyperthyroidism, hypophysitis, adrenal insufficiency. So in oncology now, if you have an oncology patient, we used to worry more about neutropenic fever, low white cells, things like that. Now you have to be more worried about autoimmune toxicities of checkpoint inhibitors, especially adrenal insufficiency patients who come in. The autoimmune toxicities, though, can also include autoimmune pneumonitis or pneumonia, which can cause respiratory failure and death. It can cause hepatic failure, autoimmune attack on the liver, and also kidneys. So patients on checkpoint inhibitors can develop these autoimmune effects, and it requires alertness to it. When they come in, often they just have nondescript symptoms, and they don't think necessarily it's their cancer drug, so they may not go to their cancer doctor with their diarrhea. It's partly on us to explain that they have to pay attention. Now, so bottom line, it's a tough decision to give a patient with metastatic melanoma the combination of the two drugs. We feel it gives them a better opportunity for a long-lasting response to get CTLA-4 plus nivolumab or pembrolizumab, but the toxicity is significant. Many patients with metastatic melanoma are elderly, and I typically don't give them, if we're going to give them, I don't give the combination. I didn't show all the data from the trial, but patients who get nivolumab by itself, a PD1 inhibitor by itself, do pretty darn well, and it's not clear that the added toxicity and expense of the Ipilimumab are warranted, except in very young patients who are fit. Well, I want to just touch base briefly on another use for checkpoint inhibitors, and that is stage 3 melanoma for surgeons or others involved in the treatment of melanoma. The common thing is to find patients with regional lymph nodes that are involved by melanoma at the time of their resection. These are stage 3 patients. And for many years, the best we had for these patients was a drug called interferon, which was given for a year in duration. A month of that was high-dose interferon, made people very, very ill. And it barely worked. In fact, we were never really sure who it worked in. And it was always a struggle to get up your nerve to tell a patient they should do it, because it was pretty tough. Anyway, when Ipilimumab was shown to be effective as having a survival advantage for stage 4 melanoma, this trial was designed to look at its use in stage 3 melanoma. So these were patients who had stage 3 melanoma resected or had stage 4 melanoma in which the metastasis could also be resected. Patients were given Ipilimumab every 3 weeks for 4 doses, followed by every 3 months for 3 years. And they looked at overall survival and the usual endpoints, and were able to show an improvement in overall survival in the group that got Ipilimumab. And there was here you see a 42% rate of severe, that is grade 3-4 immune toxicities in patients who got Ipilimumab. So because there was a survival advantage, here's the survival curves, relapse-free and overall survival. Because there was a survival advantage, Ipilimumab was approved and was in use, and this is in 2016. However, very quickly, the checkpoint inhibitors, the PD1 inhibitors, were also studied in stage 3 melanoma, and they were compared to Ipilimumab, and this study was just published in November of last year. nivolumab in this particular, or sorry, pembrolizumab in this particular trial showed 12-month recurrence-free survival of 70%. The grade 3 to 4 adverse events, that is the side effects from the drug, in the nivolumab group were 14% and 45% in the ipilimumab group. And so not only is the PD1 inhibitor better at preventing recurrence of stage 3 melanoma, but it's a lot less toxic. And it works better, this is hazard ratios, in almost every population of patient, whether they have PD1 expressed on the surface of the cancer cell or not, and whether the melanoma is BRAF mutant or not. So in every case, nivolumab is better than ipilimumab, and so now it is the standard adjuvant therapy for stage 3 melanoma. Side effects, and I think I should speed up a little bit here, but side effects are way less. You can see the side effects that patients get: fatigue, diarrhea, nausea, hypothyroidism, hypophysitis. If you look at that particular side effect, I'm going to get back to that, 10 or 11% in patients with ipilimumab versus 1.5% with nivolumab. This is a potentially life-threatening side effect, which, patients can come in with Addisonian crisis, a very low immune system, or very low cortisol, and shocky and very, very ill. And so this drug is a drug you should remember. It can cause more side effects and a lot more hypophysitis, adrenal insufficiency. So it's a drug we're using much more carefully now that we have better drugs. Okay, so melanoma, these drugs are used in metastatic disease and also as an adjuvant after resection of stage 3 or resectable stage 4. Let's switch to lung cancer. So we've always known, or we've known for a long time, that melanoma is a malignancy that has, it occasionally has immune responsiveness. But lung cancer, I just didn't think that these drugs were going to do anything in lung cancer, but shows who knows what. But these drugs were initially studied in patients with metastatic squamous cancer, and they were studied initially in patients who had failed, what we like to think of as our best drugs, the cisplatin combination chemotherapy. So patients had, sort of like the patient I had treated with 3 different chemotherapy regimens, those were the patients who got to get these drugs first. And those patients just don't do very well historically. They live less than 6 months. Very few survive more than 2 years, 5%. So this was one of the first published trials. This looked at squamous cell cancer and compared nivolumab to one of our standard of care options for relapsed lung cancer, docetaxel, a very toxic chemotherapy, tough drug. And they were able to show in this trial that there was a survival advantage of 3 months. Doesn't sound like much, but it did equate to a 41% lowered risk of death, and the 1-year overall survival was nearly half. The median time for response was fast, and patients who respond, some respond for more than 20 months, which we just don't see in lung cancer. Again, here's the survival curves on this, again, very sick population of patients. You look at, you're almost 30 to 40% of people who are alive at 2 years. Again, that's more, the standard for that was less than 5%. Another investigator looked at patients with non-squamous lung cancer and again compared the drug to docetaxel and was able to show an enhanced overall survival, higher response rate. And again, these are patients who had been previously treated and were sick. The median duration of response in the checkpoint inhibitor treated patients was 17 months compared to 5 months with the chemotherapy. Here are the survival curves with this. So this was published in 2015. So the drugs, the PD1 inhibitors, were approved for the treatment of relapsed refractory non-small cell lung cancer around this time. That's when my patient that I presented at the beginning came in. One of the struggles for us, because these drugs are high price, and who is going to respond? Can we pick out which patients are likely to respond? And one of the markers that the pathologists are hearing us ask about now is my patient PD1 positive or negative, and how can we determine that? That's become one of the standard things that we check for in patients with advanced lung cancers. Are you PD1 positive or negative? And if you're positive, how positive? So this is a trial that 495 patients, they were able to demonstrate that patients who had a higher PD1 level had a higher response. And here's the kind of example. If you have more than 50% of your cells expressing PD1, you seem to do better with these drugs than if you don't have PD1 inhibitor or PD1 in the cancer. Here's sort of an example. I'm not a pathologist, but you can see it gets browner in the patients who are high expressors. And this is just a higher magnification of the same thing. So now patients who come in with metastatic lung cancer who have a PD1 level like this, we feel like they've kind of they've gotten the golden ticket. They get a high chance of responding to a very non-toxic drug. Another predictor of response to PD1 inhibitors is something called tumor mutation burden, or TMB. And this is a variety of studies that have shown response rate to checkpoint inhibitors goes up as your tumor mutation burden goes up. Merkel cell cancer, sort of an outlier here, but the more mutations, melanoma being one of the highest mutated cancers, the higher chance you have of responding to a checkpoint inhibitor. So this is counting tumor mutation, counting how many mutations you have per segment of DNA. So because the drugs were so effective in the relapsed and refractory setting, and because the response was higher in patients with high level of PD1, a trial was done, a Keynote 24 trial, looking at giving these drugs, giving pembrolizumab in this case, as first line to metastatic lung cancer. The comparison was to standard chemotherapy. And at the time the trial was done, I think people had a lot of anxiety about, gosh, we're not going to give these sick people with lung cancer chemotherapy. It's almost heretical to not do that. But in any case, they did the trial, and they were able to show a survival advantage. If you just take somebody who walks in the door with a lung cancer, metastatic to liver, brain, wherever, and they have a high PD1 level, they're able to show a significant survival advantage to single-agent PD1 inhibitor over chemotherapy. So again, this shows the patient population. Most patients were males, past smokers. They took all-comers, squamous, non-squamous. They took brain metastasis patients. And they had to be relatively good performance status. And here's what happened. The patients did very well. So 40% had progression-free survival at 18 months. The benefit appeared to accrue to patients in every group, just about. Maybe a little less in never smokers. Never smokers with lung cancer don't have as many mutations. But anyway, because now if we have a new patient with metastatic lung cancer and they have a high PD1 level, we can treat them with pembrolizumab single agent, and they don't get chemo. They don't get hair loss. They don't get nausea and vomiting, and they feel better and do better. So the other trial that was done around the same time was, well, maybe we should add the checkpoint inhibitors to chemotherapy. Maybe that would be a good idea. So this trial compared checkpoint inhibitors plus chemo to chemo alone. And again, they were able to show a higher response rate, 47%, nearly 50% responders in the combination group compared to 19% in the chemo group. The duration of response in patients who responded was 11 months compared to 8 months. And again, here's, if we combine chemotherapy with pembrolizumab, you're getting responses, almost 70% of patients are responding. Or, sorry, not response, this is overall survival, I meant to say. So 2 years, 70%. And again, it works in just about everybody, and particularly in this case, it works for patients who have less than 1% PD1, 1 to 49%, and more than 50%. So the combination appears to be good for everybody, pretty much, with metastatic lung cancer. So it makes it hard if you have a patient who has a PD1 level of more than 50%. Do you give them chemo plus pembrolizumab or just pembrolizumab alone? And these, I tried to juxtapose the two trials looking at survival. It looks like the survival is a little better in the patients who get the chemo combination, but in any case, I think the jury's still out on that. Most of the people who get the combination do pretty well. There are autoimmune toxicities added to the typical chemotherapy toxicities, but for the most part, they're manageable. Things like hypothyroidism, we can all just put patients on thyroid medication. One of the more exciting trials that was just announced and it's affecting our standard of care is, like in melanoma, we're using these drugs now in stage 3 patients. That is, patients who have not got metastatic disease, but have disease that has spread to the lymph nodes in the chest and not beyond that. Those patients typically did very poorly. The treatment was to combine chemotherapy and radiation and then stop, and almost everybody will relapse. But in this case, they did a trial of 713 patients, stage 3. Everybody got chemo, everybody got radiation together at the beginning. And then after, in a 2-to-1 fashion, they gave patients either the durvalumab, a PD1 inhibitor, for a year, or they gave them a placebo for a year. And the patients had a variety of PD1 levels, more than 20% and 22%, less than 25%, 40%. In any case, these were just average lung cancer patients, called the Pacific trial. And they were able to show a survival advantage to giving these people a year of PD1 inhibitor, the progression-free survival advantage of 55 versus 35%, 18 months it was maintained. The patients had more autoimmune effects in durvalumab group, and the median time to distant metastatic disease, which is a marker for overall survival, was prolonged in the durvalumab group. So this is the patients in the Pacific trial, patients who again had been given our best option. These are patients who have a locally advanced cancer which cannot be operated on, treated with chemo and radiation. The patients who get durvalumab for a year have a much improved progression-free survival. And again, it affects all patients in the trial, stage 3A, 3B, squamous, non-squamous, responders, stable disease patients, checkpoint and PD1 positive or negative. Also, for the cancer specialists here, or who might be listening, EGFR mutation positive patients also respond. The challenging thing in a post-radiation patient is a lot of patients develop a radiation-related pneumonia, radiation pneumonitis, and durvalumab can cause an autoimmune pneumonitis. So the question is, in patients who have a developing pneumonia, when you don't know whether it's radiation, infectious, autoimmune, we usually have to stop these drugs. So I wanted just to take a minute on managing toxicities, and there's a lot of toxicities. My patients have had a variety of autoimmune toxicities, including full-blown rheumatoid arthritis, inflammatory destructive arthritis, type 1 diabetes, which is pretty harsh. If you have a patient who has a stage 3 melanoma and you give them a year of nivolumab and they go from being a non-diabetic to a diabetic who has to take insulin 4 times a day, it's a pretty big deal. You can develop a lot of autoimmune effects, more with ipilimumab. The one we really worry about is pituitary dysfunction. We suspect it, especially in patients who come in with hyponatremia. It seems an early sign that they are developing pituitary dysfunction. And patients who develop it tend to be more men than women. 15% who get hypophysitis, the rate is about 5 times as high in men as women. Little older patients, sometimes they present with a headache. The thing people say, I've got the worst headache of my life. Shortly after starting a checkpoint inhibitor, you should think about hypophysitis. But not all patients have headaches. More patients just have vague symptoms. Weight loss, visual change can occur because the T cells infiltrating the pituitary gland can also infiltrate the stalk of the pituitary gland, which can then put pressure on the optic chiasm. So patients come in with a visual field defect. Those patients could be having an immune attack on their pituitary gland. And when the pituitary goes out of commission, all of our hormones go down, including our sex hormones. Men become, young men who are on this for metastatic melanoma come in with a testosterone level that's almost 0, no thyroid function, no adrenal function. And so we have patients who are on taking adrenal corticosteroids, taking shots of testosterone, taking pituitary hormones. So it can be a very significant and sometimes urgent situation. If we do MRIs of the pituitary gland, we see that the pituitary sometimes becomes big and then regresses as it becomes scarred and involuted. But if you have a normal pituitary on MRI, it doesn't rule out that the patient could have pituitary insufficiency. We oncologists, or I don't know, Rick Carreno is here. We're bothering him a lot nowadays because we need help figuring out how to test for these various adrenal insufficiency or endocrine emergencies. Some patients with these drugs become hyperthyroid. They come in with a Graves syndrome kind of picture where their eyes are protruding. They have very fast heartbeat. They will need to be put on drugs to beta blockers and so forth, and then they become very quickly hypothyroid. So just my last slide, just to conclude, is this field, and Steve and I were talking at the beginning, this field is really exploding. I've only talked about CTLA-4 inhibitors and PD1 inhibitors, but there are many other checkpoint inhibitors that are being studied and are soon to be approved. These are given, I anticipate these are going to be given in combination with one another and with chemotherapy. We're giving checkpoint inhibitors in combination with radiation because radiation appears to stimulate the release of fragmented DNA into the bloodstream, and this is immunogenic. So we're giving patients sequenced radiation and checkpoint inhibitors, chemo and checkpoint inhibitors, and all sorts of drugs are being tried at the same time. This is the problem. Some patients, these are the lucky patients who go into a durable complete remission, and this remission lasts for years. I've had patients who with metastatic melanoma, metastatic kidney cancer go into complete remission. We stop the drugs, and I see them 6 months later, they're still in remission. A year later, they're still in remission. But some patients are primarily resistant to the checkpoint inhibitors. So those people are a topic of research. Some people respond, but then progress, and those are a different topic of research. So there's a lot of effort being put into this now, and I think it's going to be a moving topic this is a kind of new day in oncology. I think we're just at the beginning. So, thanks. I'll be happy to take any questions.
In those people who are who get remission, who have a very good response, is there any difference in the amount of complications, side effects, and autoimmune complications in those high responders compared to the others?
Yeah, that's a good question. I think, patients, there have been studies in both melanoma, lung cancer, and others that if you have autoimmune complications, you have a higher chance of having a response to the drugs. So my patient who developed severe rheumatoid arthritis and hypopituitarism, he was one of my complete responders with melanoma. So we patients who, but we have patients who respond who don't have autoimmune toxicity as well. So, but it does appear to be that if you have autoimmune or immune-related toxicity, you have a higher chance of having a good response to the checkpoint inhibitors. Yeah.
Is there any difference in the amount of complications and so forth between different tumor types that are treated?
Well, it's a good question. I think the side effects appear to be class-specific, meaning the PD1 inhibitor side effects are the same whether you look at patients treated with Hodgkin's disease or lung cancer or melanoma. The layering on of multiple checkpoint inhibitors adds toxicity, but I'm not aware of different toxicity based on whether you have melanoma or bladder cancer or lung cancer. I think they're more class specific. That's a good question. Okay, thanks.